for joining us. We try to include a few presentations for today's session. So this, as Rajalakshmi mentioned, there is no didactic today. This will be purely case-based discussion. So we have chosen 3 patient stories for today's session. If we hopefully we can finish that today, and if you feel that there are more patient stories that you wanted to discuss, kindly let us know in the WhatsApp group. So today for case-based discussion, you have already met Dr. Sunil for session on methadone. So Dr. Sunil is the additional director of TIPS, and he will be here taking up the presentations. I'll be also be on board for taking up discussions wherever needed. So we'll start. Rajalakshmi, whose presentation is the first?
Dr. Rakesh, can we start with you, sir?
Yes, sir. You can share the screen and start.
Yes, sir, I'm sharing.
So, good afternoon. So, I'm Dr. Agesh John. I'm working in Amala Institute of Medical Science, a cancer center in Kerala State. So, my presentation is about a case. An 81-year-old male patient who was diagnosed to have right leg venous ulcer. He has also have comorbidities which include diabetes mellitus and coronary artery disease. Next slide. He presented with a non-healing wound over the lateral malleolus on the right leg for 2 months duration. He had also had complaints of pain and itching and foul smelling discharge from the same wound with ulcer site of duration of 2 weeks. He also, on taking history, for this he had a reported history of fever since 1 week and decreased sleep and difficulty walking, which was greatly compromising his quality of life, which was present since 1 week. Next slide. History of illness. The patient is a known case of diabetes mellitus for the past 20 years. 2 years back, he developed an acute coronary syndrome with acute left ventricular failure, which was treated conservatively. Here, 2 months back, he noticed that he developed itching in the right lower limb, following which an ulcer developed. Ulcer was progressing in size, it was non-healing, and there was foul smelling discharge from the ulcer site, which was blood-stained. He also had a history of fever since last week and complaints of pain and numbness, which made him difficult in walking, and he also had decreased sleep since 1 week. He was initially presented to the surgery department as usual, all patients were present, and surgery department managed him with the lower molecular weight heparins and analgesics and wound dressing, but there was no much improvement in his symptoms. And considering the comorbidities and incurable nature of the illness, he was further referred to the pain and pack department for best supportive care. Next slide. On examination of the patient, on evaluation, the patient was moderately built and nourished because he was a smoker, clubbing was present, and vitals was stable. On assessing his pain scale with the Vision log scale, he had a pain score of 6 to 7, which is moderate to severe pain. On examining the ulcer site, we found that a single well-defined ulcer, 3 into 2 centimeter on the lateral malleolus of the right leg, with depth low and sloping edges. The floor of the wound contains slough and pus. The surrounding skin is hyperpigmented, and there was a few hypopigmented lesions with the dilated veins on both lower limbs, and rest of the systemic examination was within normal limit. Next slide, please. On the coming to the treatment and significant investigations, since this pain was his main complaint, we set as a pain first. So to control pain, we started him on step 2 of the analysis, tramadol, 50 mg TAD, along with paracetamol, 50 mg TAD. And as the symptom was foul smell due to the infected wound. So considering the foul smell, we started him on metronidazole, 400 milligram TAD for 7 days, along with PPI. He was also asked to continue his aspirin and atorvastatin for his comorbidities. And regarding the psychosocial issues, his caregivers was dedicated regarding the need for saline compression, which can be done in the home itself, and proper cleaning and dressing of the wound area, which will prevent disinfection and foul smell. This was thought of the bystanders. We also advised him to apply tabmetrogen over the wound daily for reducing the foul smell and provide granulation. Next slide. He after he was sent home, and after 1 week, he presented again to the OPD. Then now the presenting complaint was inadequate pain relief, which was inadequately controlled on tramadol. So we moved to the step 3 of the ladder. We stepped up the ladder to start him oral morphine, which is 5 mg 4th hourly and 10 mg at night, 5 times per day. And we increased the dose of paracetamol to 1 gram QAD. And considering the neuropathy component of his pain, which is common in venous ulcers, We started him on amitriptyline, then MGHS, along with laxatives, and daily dressing was continuous, and he was kept on follow-up. And he was asked to come after 3 days. After 3 days, he came to follow review. Now his pain has subsided, fever and small swelling discharge has reduced, and he was able to move about and carry out his activities of daily. And he was connected to a local palliative home care service for regular follow-up of his wound and dressing. Next slide, please. Considering his psychosocial aspects, he has got 3 sons and a daughter, and he is staying with his youngest son, who is married and has 2 children. He belongs to a lower section of socioeconomic group. One of his main symptoms was his distress about the wound and foul smell discharge, which was greatly compromising his quality of life, along with pain and difficulty in walking. Patient other issues was he was a chronic smoker, and he himself believes that the smoking has led to his disease process and suffering. This was his main psychosocial issues. Yes, please. His main concern was his pain and decreased sleep was a major concern for his, considering his family members was concerned. And considering the patient, when we ask him, he believes that he will get better with treatment and is ready to take any treatment doctor advises him. He just wanted to be pain-free and carry out his activities of daily without other help and without being a burden to his family members. That's that, please. Coming to a summary, an 81-year-old gentleman who had multiple comorbidities and venous ulcer, which was infected and painful, was referred to the PAC department for symptomatic management. His main symptoms were pain and foul smell, which is greatly limiting his quality of life. With proper use of appropriate opioid analgesics and wound care, we could reduce the pain and infection, which greatly improved his quality of life. And also, we provided proper psychosocial support to the patient and the family members, which he greatly imparted to carry out his living activities of daily living. These are the main the things we have offered to him. Next slide, please. Coming to discussion point, we are used and WHO as ladder for pain management. So just want to current guidelines are used for WHO analyzing chronic wounds, pain due to chronic wounds. Also, I will like to coming to the dressing part, we use metrogel powder along with saline compress. We ought to note the current guidelines in managing chronic wounds and any role of pain intervention, such as nerve blocks or something in chronic wound-related pain, and elaborate on the psychosocial counseling needed in the patients with chronic wounds. Next slide. Thank you.
Before asking Dr. Sunil, I would like to ask other participants, how do they manage wound, especially chronic wound in their setting? Like many of you might be seeing a lot of chronic wound, either malignant or non-malignant mostly. So is there anything different that you do other than what Dr. Rakesh just mentioned? How do you manage these kind of wounds in your setting?
We do regular dressings. The patient is admitted, and home care basis. So we take the dressing gauze and the betadine and metrogel tablets. If the patient is not having that at home, most of the patients have that at home in home care settings, and there actually our nursing staff actually checks the wound when we do home cares. And if required, we in foul smelling discharges, we sometimes advocate charcoal also, which helps to reduce the smell. And and mostly if fever is there or if any other problems, then we advocate some oral antibiotics if possible.
Dr. Manish, how do you use charcoal? In what form? Do you buy charcoal tablets or the normal charcoal, and how do you use it over the year? Just for others to understand.
Yeah, so I've used it very little, only once or twice I've used it actually. So the charcoal actually first has to be washed in the what we use actually we wash it in the basin or in our setup we wash it multiple times, and then we keep it just not inside the wound, to keep it just around the wound. So it actually absorbs the smell mostly. It doesn't have any healing effect, or it doesn't have any repairing effect of the wound. It mainly absorbs the smell. And there is an hospice in Chandannagar. They actually make charcoal from the wood, and they make the homemade charcoal there. but we don't have it here in Kolkata. So we mostly buy it raw charcoal and then wash it multiple times before placing it just near the patient, not inside the wound. I don't know if it's the right method, but these are used only once or twice only. Other people can suggest, or madam, you can suggest if
Then there is a question. Do you powder the charcoal or you use the big pieces?
no, we don't powder it. Like I've not powdered it yet. No, I've not seen it used in a powder
So then
form.
how will you keep the charcoal blocks near the wound? Like how will you?
Like in a smaller, in a gauze piece, we wrap the charcoal around, and we keep it near the wound when the smell is too much. Like it's not for regular use. We have not used it in a regular basis, and some patients do have better effects with natural tablets and all. And if there is extreme smell and extreme discomfort to the patient for the smell, and then we place it near the wound, not inside the wound. I have not actually used it inside the wound till now. And in a small gauze piece wrapped around the charcoal, we keep it around the wound.
Thank you, Dr. Manish. Dr. Adul, would you like to say a few words about the vacuum dressing?
No, ma'am. In our setting, we are not using vacuum dressing, but I have heard that in Ernakulam GH they are trying vacuum or negative pressure dressing, and it has proved to be very effective in chronic non-healing ulcers. That's why I put that.
There is
In
a comment
CMC
from Dr. Sangeeta. Yes.
In
Please.
CMC Vellore also they use vacuum. That will reduce the swelling, and the liquid from around the wound will be reduced very fast. So the wound will be dried, and when the wound is dried fast, the infection also will become less very fast, and wound heals also very fast. Recently, somebody from CMC Vellore was telling about this vacuum dressing, what they do. They have special machine apparatus that is the cup is placed over the wound, and so the humidity and the fluid around the wound is sucked out.
Thank you, Sister Lisa. I think Dr. Anjali has commented that they use vacuum dressing. Yes, Dr. Sangeeta, we can use the charcoal blocks under the patient's beds also inside the room so that the foul smell is reduced. Sometimes we do get charcoal tablets that can be crushed, but not directly over the wound, but above our layer of dressing. So I'll ask Dr. Sunil about this wound management. So there are few questions also, like about the use of soda bicarb to wash the wound, etc. And maybe a little bit about the vacuum.
I think somebody told that they are using Dr. Is that Dr. Anjali?
Yes.
So let Dr. Anjali explain what they do. Dr. Anjali, would you like to explain to
Yes,
others?
So this is a device, there is a vacuum pump, and it is that cup is placed over the wound, and it is continuously draining with the normal saline, and then it is suctioning out. So we are sending the patient with the vacuum machine to the home, and they will come back after 10 days with that is draining in in a bag. When it is full, or if they are having any discomfort, they are coming back, and we will redress this thing as continuously. Again, we will remove that, and again the flushing and suctioning out. So we have a lot of patients, and regularly 2 or 3 people are sending out this with this vacuum pump, and within 10 days or sometimes within 2 weeks, the any non-healing ulcer will be healed, and the skin graft is we could place the skin graft over the wound.
So what vacuum pump do you use?
Sir, that vacuum pump, that is, it's a machine specially devised, and the company is providing. And it is cost 10,000 rupees for 10 days, actually. There is, we are not using, we are, that company itself will come and they will dress it, they will, give the patient itself, they are paying from, to the company. But it is a very good device. A lot of patients are and benefiting from this.
Okay. Okay. So, as you told, I have had of 3 types of platform which is used for wound healing. One is the thing which you have told. It is the proper negative suction, and which is happening with the vacuum pump. But somebody else used the drain which we put after the surgery to drain the fluid. So that can be also used. What we use is in a low cost setting. Either you can use the suction, the drain which is used after surgery, or the wound is covered with a sponge, and in the center of the sponge a hole is made, and small tube is inserted in the sponge, and that tube is connected to the suction apparatus, and continuous pressure is maintained with the suction apparatus. So the advantage is that the wound will become clean. Maybe it will take 5 to 7 days. Otherwise, sometimes the wound might require debridement. So that can be avoided with the negative section. So Dr. Abdul was talking about the section which people at General Hospital use. That is they use the suction and drain, okay, which is put after surgery, and it is connected to urine bag or something. So that's the very low cost thing. But I do not have experience with that. But we do use the suction apparatus and the sponge to apply the negative pressure. But these are things which are now coming up. But usually, what Dr. Rajesh has told is the application of Metrogyl and if needed, wound debridement. Even with ointments like the debridase, which contains papain and urea. So papain enzyme, which is a enzymatic debridement, which can be done with debridase ointment. And soda bicam, it is not usually used. It is the normal saline is used for cleaning the wound. And maybe even betadine might be used if there is once the dead tissue is removed, then you need not use betadine. You need to use only the normal saline. Otherwise, it will impair the wound healing. Yeah, silver dressing. Yes, that's also. So regarding the wound care, there are no guidelines as such to suggest, because so from this group itself, we had many opinions. That itself indicates that there is no guideline. Everybody uses their own expertise, and they use different dressings and methods. So yeah, even hydrogen peroxide, it might be used in the when the wound has the. Otherwise, if the wound is in the healing state, no hydrogen peroxide. The bromide tablet with Metrogyl. Okay, Dr. Veggie. So Dr. Veggie, Why do you want to use the loperamide tablet? Anybody? Any of you have used the loperamide tablet?
I have not used loperamide, but somebody says sodium valproate is useful. Somebody told in chronic wounds, sodium valproate tablets. It provides granulation or something. I have not heard loperamide.
Okay, Dr. Reggie, are you there?
It was once said in one of the palliative care classes, I think. I have attended this one.
Okay, so loperamide actually is a locally acting opioid. So it can give pain relief. So some people also use loperamide in the powdered form to give pain relief. But previously that was used a lot, but I think now the interest has decreased. I think the other thing which you can use is local anesthetic, which can be applied locally. Maybe buprenorphine 0.1 to 5% can be used, and that can give good pain relief. And even some people may not get pain relief with oral medication, and even in such patients, if you apply buprenorphine locally, maybe you can 2 milligram per kilogram body weight, and that can be taken in a syringe, and then just spray on the wound, and then put a gauze, and then the remaining can be emptied on the gauze. And maybe this can be repeated every 6 hours or 4 hours even. So they will have pain. And the chronic wound pain management as such, there are no guidelines, but we have to understand that the management of cancer pain and management of pain in non-cancer patients are different. And there are many recommendations about not to use opioids as a first-line medication in case of chronic non-cancer pain, because we know that in case of chronic non-cancer pain, the chance of psychological dependence might be more. But the advice is you have to use non-pharmacological management, and then come to pharmacological management without opioids. And if that is not going to give much relief, then you can give a kind of opioids, but with every visit you have to actually assess the patient for risk as well as for the benefits. And if you find that benefits are more, then you can continue to use it for some time. But the follow-up and the follow-up would be more frequent when you put patient on opioids, and it will not be for lifelong. And I understand that probably the patient, this patient, because of the infection and inflammation, the pain might have increased. And when you have given metrozole local application antibiotics, then probably the pain might have reduced also. So I think you might also try to taper the dose of morphine and see how he is responding. And as I told you, application of injection buprenorphine locally is another option that you need to try. And when the wound is in the acute stage with infection, probably NSAID might also have a role because there would be some inflammation. So that's my opinion regarding the management of pain as well as
One more, if the wound is bleeding slightly, so there's a bleeding from the wound, is there anything tranexamic acid we can powder and use something bleeding wounds?
yeah, that can be done because there are many measures have proposed like powdered encapsulate, tranexamic acid injection, apply locally, and even people advise sucral phase. But all these do not have much evidence, but people use it to practice. And yes, if it is bleeding from the capillaries, that will give or that will stop the bleeding. But if there is major bleeding, that is not going to be stopped by the application of tranexamic acid or encapsulate properly. And as you have asked that question, I think one of the important things which we need to be do during the wound dressing is before you remove the dressing, you have to actually soak the dressing for at least 20 minutes with a normal saline so that it will not adhere to the wound. Also, if you don't soak and take it up, the chance of bleeding would be more, the chance of pain is also more. So that's also, these are simple things, but I think this is important from the patient perspective.
Also, I would add that you can continue tap metrogyl low dose continuously if there is foul smell. Is it also clinically right? Without stopping metrogyl, we can continue tap metrogyl continuously.
Okay, so there is a observational study from CMC Vellore on the use of continuous metronidazole tablet, not in case of chronic non-malignant wounds, but they did this observation. They actually reviewed the cases of patients with malignant wounds for the last 15 years. And what they found out was when you give metronidazole continuously, that can prevent foul smelling. But I think that may or may not be applicable in case of a chronic non-cancer wound. So in case of cancer wounds, there is something called as sniff rating. That is S is for smell, NI for nil, smell nil, then F for chain, the next F for forbidden. So you will give first when the patient present with foul smell, you will give course of metronidazole, maybe 400 milligram TID, 5 to 7 days. Then followed by you will give metronidazole 200 to 400 milligram on a once daily basis. So this is what they advise. But I also understand that many patients with the metronidazole complaints of metallic taste in the mouth as well as nausea, vomiting, gastrointestinal side effects. So that's another problem which we need to take care. I think it will depend on, or it will vary from patients to patients, and yeah, we have to consider it on an individual basis.
So I hope you have answered all the questions, Dr. Rakesh.
Yes, ma'am. Okay. Yes, ma'am. Thank you.
And I think there was another question on psychosocial counseling. I think one of the important problem that we need to address here is the wound can cause many problems. Even the foul smell can cause many psychosocial problems because the patient even might be isolated because of the foul smell. The people may not enter, he may not get the proper care. So it is important for us to talk to the caregiver and tell them what needs to be done to reduce the foul smell. and also the importance of keeping the wound covered, because otherwise the chance of forming maggots. So we should explain why maggot infest wound. So the houseflies, which is attracted by the smell of the wound, will come and lay eggs in the wound, which can actually hatch out as maggots. So that explanation should be given. And if possible, a mosquito net also can be used. And the formation of maggots would be more in the lower lower socioeconomical strata, because of their ignorance and things like that.
Can we move on to the next presentation, Rajlakshmi?
Dr. Manish, over to you.
Yeah, good evening, everyone, respected faculty members and their colleagues. So, I'm currently working as a pain and dietitian consultant in Sabapur Cancer Hospital, Kolkata. My name is Dr. Manish. Go to the next slide. So, my case, my patient is a 56-year female. Was diagnosed with a metastatic right carcinoma of the breast and with brain metastasis. Next slide, please. So we were used to visit the patient in the home visit and home care, but the patient got admitted in our emergency department with these complaints just 2 weeks back, and she had disorientation, drowsiness, serious unconsciousness with shortness of breath and anorexia. I'll come to the duration in the next slide. Next slide, please. So she was apparently well 2 weeks ago, and she complained of drowsiness and disorientation with shortness of breath in the last few weeks, and it was gradually progressive. And her husband complained of few episodes of unconsciousness, which happened in the last few days, 2 or 3 days. And she had severe anorexia and not able to take anything orally. And whenever she takes any food or any liquid orally, she had some discomfort in the neck and the thorax, in the tragus and the feeding tube, feeding pipe. So she also developed tremors and involuntary movements in her left leg also. And in the comorbidities, she is a known diabetes, hypertension, hypothyroid, on medications for the last few years. She has been diagnosed with the right-sided breast malignancy 4 years ago, for which she underwent surgery and then chemotherapy. But there was a recurrence of tumor, and that happened with the previous 2 years. She was allergic to the sulfur drug, and she had a history of psoriatic rashes over the extremity. Otherwise, her sleep and appetite were significantly reduced with a normal bowel and bladder habit. In the family history, she had her elder sister who has a history of breast cancer, and her father's history of oropharyngeal cancer. Next slide, please.
Dr. Manish, I doubt your internet connectivity. Can I off your video?
Sure. Yeah.
Okay.
Okay. So, yeah. So on examination, she had a lower blood pressure of 90/60 with a pulse rate of 100 per minute, and saturation was 70% on room air, and with a normal temperature with the GCS of ECVC and force. They had significant pallor and pedal edema, and on observation, she had bilateral capitation. And her skin was dry with rashes over her extremities, and her pain score could not be assessed because she was not able to communicate properly. She didn't have any great score, and her oral cavity, some few dry ulcerative lesions persist. Next slide, please. So coming to the treatment, initially we gave her oxygen through the non-repeating mask at 10 liters per minute to pick up saturation. We had an injection of dexamethasone and mannitol and pantoprazole. For the oral ulcers and diabetes, hypertension, hypothyroidism, we gave the supporting medicine. And we putting in rice tube because she was not able to take anything orally because of her disorientation and not able to communicate properly. So we had to put in a rice tube for her oral intake was also poor in the initial period. She has significant anemia and in her recent blood report we had 5 gram percent, so we had to transfer 2 units of PRBC. And this was the short past history where she had the surgery done 2 years back, followed by some cycles of chemotherapy cycles. And after that, still to resolve the disease because the whole body CT scan shown some recurrent lesions, and particularly in her breast and mainly in the brain. And she then received 10 cycles of radiotherapy, after which she was well for 10 months period. Then she was shifted to oral chemotherapy. But again, after that, we received the patient around 2-3 weeks back when she was referred and transferred to palliative care due to gradual deterioration of her general well-being. And from then, we saw the patient for last 3 or 4 weeks, where we started home care and she got admitted just 2 weeks back. Next slide. So these are the medications which were given in the treatment phase. Injection mannitol and dexamethasone and levetiracetam. It was initially for the brain mets because of cerebral edema, and initial laxatives were also given. Proper oral hygiene and care was given so that there is no infection in the oral cavity, and so that we can mobilize oral feeding quickly as soon as possible. And we started on the home medications when she got a bit stabilized. Initially, she had to be kept in an ICU for 1 or 2 days with proper explanation and consent from the relatives. And after that, 2 days, she was shifted to ward, and other supportive measures like the antibiotics and antipsychotic treatments were continued. Next slide, please. So coming to the psychosocial aspect, so the patient had her husband and her son by her side at home, and the husband's brother in the next house close by to look after her. So her husband was a primary caregiver, and he had a margin of 21,000, and her son was studying post graduation in geography. There was actually no health insurance to cover for her illness, and so they were in a bit of economic crisis. And when they came to know around 3-4 weeks back, they were transferred to palliative care. They got very anxious about the lack of further treatment options and depressed also at the same time to cope with the situation, because they were expected and hopeful about the beneficial effects of the radiotherapy. And when shifting to oral chemotherapy, they got that idea that they might be getting better in some aspects, but this change of treatment, or you can say addition of treatment of palliative care, really taken the whole family back, and they got very much anxious and depressed about the whole scenario. So in the emergency situation, emergency admission, and it has to be counseled multiple times the family about the subsequent illness and how to cope with this illness in the palliative care unit, and so that we can give a proper support and touch time. Thank you. Yeah. So the main concerns for the patients, one was economic burden because of the carrying forward of the treatment, and second was the patients and the family, particularly the anxiety and the depression because of the future treatment options given their expectations in the previous phase of the illness. And also there is inability to take food orally, because that was a preliminary complaint of the patient and her visit when we were actually attending at home, when we received the palliative care call. And that was initially the main problem the patient had. She's not able to take anything orally because of something stuck in the throat and not able to swallow properly. And that led to very poor oral intake and the further problems that occurred afterwards. And also there was some uncertainty about the quality of life after they're getting discharged or sent home for home care. So there was very much uncertainty around the patient's quality of life. So this was the main concern. Next slide. So yeah, so To summarize, so she is a 56-year-old female patient with a metastatic right-based carcinoma with a brain metastasis complaining of disorientation, drowsiness, episodes of unconsciousness, process of breath and anorexia, and with significant pallor, variable fat, underwent conservative treatment for prospective failure and along with severe psychological and economical problems, which she and her family faced during the treatment protocol. And followed which she gradually recovered for her symptoms, but sadly I couldn't update it when I was catching the treatment. The patient expired just 1 week back in the hospital only because of actually we were able to make the patient quite better of the right tube and we started giving her early very small amount in frequent means, but she had an aspiration and then again some emergency situation occurred and we also explained the patient's family about the uh, risk of aspiration when we are actually gradually shifting towards feeding. But sadly, the patient had an particular aspiration, followed which it could be recovered after 1 or 2 days of supportive therapy. And the family overall from the last 4 weeks are home, their home, and when we treated in the last 3 week period, 3 or 4 week period in the hospital, and so they were properly counseled. They come for bereavement support also. That today only also her husband came for the counseling for the bereavement. Uh, so this was actually the after I uh, wrote the case actually after this event occurred. So I couldn't update it here, but I am actually in front of you after as I am presenting the case fully, it will complete the whole case. So this was a summary of the case. This was a discussion point. What I want to know from this whole journey of the patient from start to end. So one was the tackling of psychological aspects, and one is economical problems that her family face. Third is to rehabilitation activity discussion in valid now because it will discharge her bones sadly. But what I feel is this question can be modified like what we could have done so that coping could have been better. Like we could have told the palliative care can be instituted early and integrated early. And that has helped the patient to cope with that anxiety and depression the patient and the family has. And any other treatment options that would have been available at that time because that is an urgent question I would into the house. Other things we could have done so that overall patient care could.
Thank you, Dr. Manish. There is already one comment. Um, I hope she should have got palliative care in the early course of her disease and treatment. I mean, would you like to comment on that, Dr. Manish? Do you often get very late referrals, or how does that work in your setting?
Sometimes, yes, because we had an integrated department with medical oncology. So what happens with medical oncology usually sees or introduce partly palliative care approach from their side. But yeah, we do get early care. It's not that always all patients will get late palliative care. That's mostly what I've seen in the last 1 year around 9 months around attached to the hospital. Mostly in the last 2 months to 3 months. These are the areas where I'm getting this referral and more density of the patients in the last 1 month because I'm starting to see a patient and within a month or 1.5 months the patient are there. So and when I'm actually getting it at 1 month or 1.5 months before actually when we're getting it, patients are actually very critical. So they're not in the state to actually hear you out or counsel. And those are the types those are the situations I've faced. I've tried to institute early care, early situation of early care. And, but yes, I'm getting that also, but the percentage is quite low till now.
Thank you, Dr. Manish. Any other comments from the other participants? Or any questions or anything from your experience? How will you deal with this kind of patients? How will you deal with the psychosocial issues that they're going through? Or is there any possibility of rehabilitation? And at this point of care, I mean, anything from others based on your experience? Which will be good to hear from you because this is basically a case-based discussion session, not a didactic. So we'll wait for your comments. Dr. Atul has mentioned about multidisciplinary approach, including a psychologist. So, do you have that in your setting, Dr. Manish? Do you have a psychologist in your team, or is that a service available
Yes,
at all?
Yes, ma'am. We have a psychologist in our team, and what we do, we go for rounds in the morning, then we go in the rounds with the psychologist on board, so that during the process of taking rounds of the patients admitted, we give a short brief counseling to the patient. But yes, the family sometimes is not present there. Then we tell the staff and the staff to meet the family separately in our OPD. We go back to our OPD. So after the OPD hours are completed, during the afternoon phase, we do some family counseling. And then if the family has some questions or doubts, and at the family and the patient actually counsel at the same time, we take the family to the patient's bedside and counsel both of them together if required. So we have a psychologist in our with our
That's great. I think because those kind of services are not really available everywhere. But it's very important.
yeah, I guess in other institutes are attached, so there is not much psychological background, there is no psychological counseling available. So, so I have to counsel them from my side to what I've learned from what we've done for years in research. But for this patient, I feel that this patient and her family have to be counseled multiple times during this coping period, this last 3 weeks before we turn it open, because they had an expectation that the patient will get well with oral chemo. They were focusing on the oral chemo part.
That part was not clear. I heard till multiple times you did counseling, and after that it was breaking your voice.
Yeah. Sorry. Can you hear me?
Yes.
Yeah. Okay. So the family were more focused on the efficacy and the right the outcome of the oral chemotherapy. They used to multiple times tell us that will that oral chemo will help to her to recover fully and recover to actually go to home to their last stages of life and more than the other symptoms like not able to swallow or not able to let's say, function like move about at home. More they were focused on oral chemotherapy. So we have to drag them out of that idea that oral chemo is the only thing that has to be worried about. And there are other spectrum, other aspects that have to be looked forward. That's how we have to do almost daily counseling sessions, or daily twice almost, morning and evening. And in some cases, I have to come back home, and there also I used to get calls from his husband, from my husband. And then I have to counsel a bit from my side. Then after I came back, come back home. So they were quite not in a settling mood. So they actually were shifted to palliative care or transferred to palliative care. So that was a problem. But I think early integration could have helped a bit. And yeah, any other suggestions? Um,
It was a little difficult to understand because of the network, but I could gather a little bit of information from what you were telling. I think your network was not very
Okay.
clear.
Okay, ma'am. Maybe
Dr. Sunil,
because of the
any
internet. Yeah.
comments? I think it's the internet problem because in between we are able to hear, but then we lose the
Okay.
network.
Okay, ma'am. Exciting.
Dr. Sunil, any comments from the side? And there are 2 questions in the chat also regarding examples.
Yeah, regarding the psychological support, I think was she in a condition to speak? Are you able to talk to her?
Yes, yes, sir. Yeah.
Yeah. So if she is able to talk, then I would talk to her. Moreover, I would listen to her to find out what are her concerns, and probably so that the patient will tell us what are her concerns, and depending on that, we have to involve the various team members from our team, so that she can get some help. And even you say she is in depression, and so if you have to screen with some tools like the PHQ-9, and if she has features of severe depression, then definitely pharmacotherapy need to be started along with psychotherapy. So it is not very easy to. It is easy to say we will give psychological support, but the thing is that we have to actually find out what are the problems, and if all the problems for all the problems they come up with, we would not have a solution. But at least we can hear that, and some of the issues that they bring out, we will have some solutions also, so that they will feel that there are somebody for us to hear and to act on our or to help in our situation. So that would be the psychological support that we can give. And regarding the economical problems that the patient is facing, I don't know whether this patient is fit for any treatment uh, because she was diagnosed with CA breast, I think 4 years back or 2 years back, and then now she has a brain metastasis and pulmonary edema. So
Yes, sir.
yeah. So did the oncologist advise any treatment for that?
Sir, yes. Actually, for the cerebral edema, she was on oral dexamethasone at home, and when she presented at the hospital, then injection dexamethasone along with injection mannitol was given. For which there was gradual recovery for her consciousness and also injection latex at the same time with a minimal bypass support was required for a very short duration for the pulmonary edema. But what she had a complaint also initially and during the sequences was she was not able to take anything orally, and that was a big discomfort from her side. So because anything she has to eat, some getting stuck in the throat and not able to swallow properly, and that had led to a very like aversion to food. She take any food. So we used to advise gargles, at least long-term gargles, but she was not able to follow that much comment properly. So she should speak out a bit, but she is not that fully coherent and uh, follow commands as expected. So that was a bit of problem we had to face. And yeah, during the recovery phase also.
Yeah. So I was actually asking whether the oncologist suggested any radiotherapy to the brain for brain.
Yes, sir. Yes, sir. She had undergone 10 cycles of radiotherapy for the brain metastasis. For following which she was well 10 months, for 10 months and 11 months. But after that, she was switched to oral chemo, that lapartinib and ceftazidime, and but gradually she deteriorated over a period of around 3 to 4 months around after the radiotherapy was over, and then they shifted to palliative care and the transfer to palliative.
So palliative care came into picture only in the last month.
Yes, sir, almost the last 1 month almost.
Yes.
So that,
So that is the problem. So otherwise, I think when actually palliative care should be involved in very maybe at least when she was diagnosed with the brain metastasis,
Yeah.
at least. But so when the patient suddenly transferred to you, then you do not have any option. Otherwise, I think this situation would not have happened. We should have actually talked to her and to her family regarding what is going to happen, and what we can do at that situation. All those things should have discussed if palliative care were involved much before. But I think this is what you can do because you were involved in the last time only. And regarding the dose of dexamethasone, usually it is maybe 8 to 16 milligram, but there are some situations in which people have used very high doses of steroids, the dexamethasone. Maybe even up to 100 milligrams have been used, but the usual range is maybe 8 to 16 milligrams.
So we used to give 8 milligram TDS, sir, injectable, then oral dexamethasone to 4 milligram TDS, and when we actually got better.
Yeah, sometimes many patients who have brain metastasis or primary brain malignancy, they might need to be maintained on steroids for lifelong. For some patients, you might have started with 16 milligram, but when you come down to maybe 4 milligram, and then you try to reduce, the patient might develop symptoms like headache and things like that. So we will again increase the dose of steroid. So you have to find out the minimum dose which would help the patient to live with a good quality of life, and that need to be continued in some patients if they have symptoms.
But one more thing, sir, the patient has an allergy to sulfur drugs. So initially, when we got a referral, she had a bit of pain also in her neck and hip region. So we thought it was a maybe due to the positional, not much of movement, and the patient was not that much mobile at home. So after that was not that much mild, it was around moderate to severe. So we gave her a dose of morphine, but she had an allergy all over the body, and then we shifted to paracetamol only, and rather than going on any other sulfur drugs. So, sir, one question. So, usually patients is like have an allergy to sulfur drugs, and then for pain, can we use like paracetamol, or we can have an additional medication for those kind of patients? When an allergy to sulfur drugs, not in sulfate.
So allergy to sulfur drugs, paracetamol is not a problem, isn't it? Because sulfur drugs, it is sulfasalazine and sorry, sulfaxacin, the cotrimoxazole, wasn't it? So I do not think there is any problem in using the other medication, paracetamol or NSAIDs or opiates.
Okay. Thank you.
Sir, maybe you have one more question. Any role for oral glycerols?
I think the only one that which is actually advisable in case of malignancy and which produces seizure or symptoms, brain metastasis, etc. It is dexamethasone because even mannitol may not be of much help in those patients because malignancy can actually cause the blood-brain barrier, and the malignancy can cause many problems with blood-brain barrier. And actually, the blood-brain barrier need to be intact for the mannitol or any other agents to work. And most of the time, blood-brain barrier is not intact in case of malignancy. So, but dexamethasone would be useful in such conditions. So dexamethasone is the one medication which is going to be useful in such condition, and I do not think glycerol would add much into situation.
Okay.
Yeah, I agree with that. Glycerol doesn't have much role. Plus, it is very difficult for the patient to ingest. I mean, it's nothing. It's not something pleasant, and they find it very difficult to swallow. And there is not much market difference or much of evidence in support of glycerol. As sir mentioned, dexamethasone will be the best drug at this situation. Thank you so much, and we'll quickly move on to the third presentation. Thank you so much, Dr. Manish.
Thank you.
Dr. Sangeeta, over to you.
Yes, am I audible?
Yes, ma'am. Yes.
Okay. I want to introduce myself. I'm Dr. Sangeeta Subba. Basically, I'm a like a physician, but I was trained in palliative care in foundation course. So I'm looking after palliative care. But I'm working in a district hospital in a periphery. So this presentation, I'm just trying to present, saying that we are also doing at least something in the periphery, then doing nothing at all. Because in our team of palliative care, we have only me as a doctor and 4 nurses whom I've recently trained. And there are no other team members. So we are just trying to do something for the patients, that much only. So I'll present my case. Next slide, please. So we had this female patient who's 51 years old, and she was admitted on 8th of January 23. So she was actually diagnosed with carcinoma base of tongue, and she had post chemotherapy, radiotherapy, and it was operated 4 years back. But this time she was admitted for anemia, bleeding from the wound, pain, and she was not feeding due to pain. And this case was referred from nearby CHC for mainly for complaint of pain and non-maintenance of SpO2. Next slide, please. Her presenting complaints were pain over the wound and bleeding from the site. She also had difficulty in feeding and shortness of breath and generalized weakness. Next slide, please. No, history of present illness is a 51 years old lady who was diagnosed with CA tongue and was operated about 4 years back, attended with chief complaint of pain and bleeding over the site of wound for about a week. The pain was somewhat bearable in the beginning, as the attendant said, but it slowly increased in intensity and became severe and stayed throughout the day, affecting her daily activities. She was given some painkillers from the PHC initially, which helped her to some extent, but the effect slowly got lost and she used to be in pain throughout the day. There was also some amount of bleeding from the wound, which got controlled with dressing and medication. The patient also complained of difficulty in feeding due to the wound, which made her very weak. The patient was also feeling shortness of breath, due to which she was unable to sleep well at night. Next slide. On examination, on general physical examination, she had a depressed look. She was cachectic. Her blood pressure was 90/60 and pulse rate was 76. Her SpO2 was 76% in room air. Pallor was there, but systemic examination was normal. And on local examination, her mouth was swollen and jaw was also swollen due to local spread of the wound. It was hard in consistency on palpation and it was tender to touch. Next slide, please. The treatment and significant investigations done were on her hemoglobin showed 8.5 gram, ESR was 40, TLC was 13,700. Rest of the CBC was normal. Chest X-ray also was normal. Ultrasound whole abdomen showed bilateral kidneys, slightly raised cortical echo texture. The rest was all normal. LFT was normal and KFT showed mild derangement. On treatment path, patient was initially admitted under ENT department for complaint of bleeding from the tongue, from the wound, and the consultation was sent to our department, that is medicine department, for the pain and shortness of breath. On examination, we found that the patient was in pain and she was literally crying. And feeding was also not done for more than a week due to huge swelling of mouth and jaw due to the CA wound. Her sleep was disturbed and the patient's attendant, who was her daughter, was very much frustrated due to patient's symptoms, irritability and anxiety. So we shifted the patient to our side as there was no active intervention needed from the ENT side as discussed with the ENT surgeon. Next slide. Medications that we gave to her, we transfused 1 unit of blood. IV fluids were given, injectable antibiotics, injection pause, injection hydrocortisone, derifylin, and tramadol initially, and nebulization was done, and even oxygen therapy was given. We also gave clonazepam 0.5 mg at bedtime to alleviate her anxiety. And then her cry was continuous, so we thought of starting morphine and we started with 10 mg TID initially. Then we titrated the dose as per the need. RAS tube insertion was also done for feeding. And on 16th January, that is after 9 days, her peripheral veins became inaccessible. And so venesection was done. Patient recurrently went into shock as her feeding was very, very minimal. And she was also not eating at all. And I mean, she was not eating, and the feeding tube was, because her feeding tube, we could not insert the appropriate size due to the obstruction. So we had just inserted a small size tube through which we could give only few liquids. That also patient was very much irritated and she used to refuse feeding because of pain also maybe. The patient continuously complained of dyspnea and discomfort in the throat due to the recurrence of the growth, and which was also obstructing her airway. And then again we took ENT expert opinion on 18th January. Then they suggested that high-risk tracheostomy can be done, which was suggested, and the patient party was also explained about it. So they agreed for that and they wanted to undergo tracheostomy. Next slide. But unfortunately, patient suffered cardiac arrest in OT before performing tracheostomy, as she was in very poor general condition. We had explained to the party, but they also, out of frustration, maybe they wanted to do whatever could be done in the hospital, so that hoping that she might feel better. So in spite of our explanation that it might not be helpful, they were prepared for tracheostomy, but tracheostomy could not be done and patient suffered cardiac arrest in OT. So she was resuscitated and revived well with vital stable. And then we shifted her to ICU. Tracheostomy was postponed, but on 20th January, again she collapsed. And after that day, she could not be revived back, and she expired on 20th January at around 1 p.m. Next slide. Her psychosocial aspects were the patient had her husband and daughter to look after her, who were both unemployed. The patient and her daughter both were frustrated due to the disease process. The patient used to get angry with her daughter out of frustration most of the time. And whenever we used to go for a round, they used to be fighting all the time. The patient was disappointed for the hopeless life that she was living. She was irritated for being unable to eat or drink. She was angry with God for punishing her this way. She was from very poor background, so much so that her husband could not afford to come to hospital when she was dying. She did not want to go back to her home for fear of pain and dyspnea. That's why we tried counseling her, but still we could not send her back home when she was a bit stable. She was cut off from all social responsibilities and contacts after her disease. As per her daughter, she lost her earning way for being a primary caregiver and exhausted whatever fund they had earned so far. The pain of being poor was more than the cancer pain. This is my perspective. Next slide, please. Main concern that we found in her case was shortness of breath, pain, unable to eat or drink, and discomfort in the throat. The primary caregiver, which was her daughter, was worried that her mother is not eating well, which according to her was the main reason for her suffering. Next slide. Summary: a 51 years lady from a poor socio-economic status, a housewife with carcinoma base of tongue, post chemotherapy, radiotherapy, and surgery in the last 4 years, with recurrent growth and associated symptoms of dyspnea, discomfort in the throat, pain, difficulty feeding, with anxiety and irritability, admitted for bleeding from the wound and palliative care at district hospital. The patient expired pain-free and peacefully after 13 days of hospital admission. Counseling was given to family members post-death, after her death. Next slide. So these are the discussion points. Caretaker issue was seen due to the irritability and anger by the patient. And caretaker's issue regarding the feeding of the patient was also noted, because this was her main concern, that she could not feed her well. So she thought that maybe she's becoming weak and becoming seriously ill, all because of feeding issues. The patient and the caregiver lost all hopes and had become emotionless for upcoming death. So I just want to know from everyone, experts here, how to counsel in such situation. And patient could not be counseled to go back home. This I already mentioned, for fear of pain. So this she stayed for like till her death, which what we felt that even after her pain was reduced, she was not confident enough to go back to her home where her family members were there. So she died only with her daughter beside her. How to initiate conversation regarding decision making in such patients, because she's from such a poor socioeconomic background that what I felt was that she's unable to understand also properly what we wanted to, like to give her a quality of life and quality death. So this was the issue with us, with our team during her hospital stay. And next, counseling regarding grief and bereavement to the family. Though we are trying our best, but still so many experts are here. So I want to know from the experts so that in future we can do much better than this. Thank you.
Thank you, Dr. Sangeeta. I think you've
Next
done-
slide, please.
Thank you. I think you have done a lot already, but indeed a difficult
Thank you.
situation to deal with also, given your setting. And I understand you have a very small team, but you have done your best for this patient. So, but I would like to hear from other participants. Is there any questions or any suggestions to Dr. Sangeeta? I mean, what will you do if they lost all the hopes and become emotionless for any further counseling? I mean, do we need to intervene, or is it okay to be like that? So, I mean, any comments? Yeah, there is a comment from Dr. Atul that in case of terminal illness, maybe revival of first.
Ma'am, I want to say something in this regard.
Yes, please.
Actually,
Yes.
in our district hospital, we are only 2 medical specialists, and I'm the only one looking after the palliative care besides my medicine. So what had happened actually? Hmm. So actually, what had happened is, if I was there, I would have refused for that tracheostomy plan. But since we are only 2 in the department, medical specialist, and that too, I'm looking after medicine as well as palliative care. So that day I was not there, to be very frank. So they planned that way, and then maybe I was thinking out of fear also she could have gone under arrest. But I want experts to speak over this matter.
Yeah, it happens, I think, very often when you're working in a hospital setting, where even after we communicate with the other team, probably when the time comes, they will do the routine so that they are not blamed of not doing anything. Or I've seen or heard participants sharing such experience. Yeah, I understand that you are not on duty at that time. Dr. Sunil, anything to?
So first of all, I think Dr. Sangeeta, you did your best to support the patient and family, and I would like to look at this patient from another angle. So that this patient had a very advanced medical history. With she was bleeding. She had breathlessness, probably due to obstruction, and she was not taking anything, and her general condition was very bad. So, but I would note in such situation is that after assessing the patient situation and discussing with the patient family and patient, I would then make a plan with their consent by involving them. And probably what I would tell them is that at this point of time, we need to mostly concentrate on quality of life, and we would help you to we would help you to attain those um, symptom control, like relieving breathlessness and probably reducing pain, things like that. But and as you are in the hospital, sometimes if your breathlessness increases, um, then there are there is a choice of putting a system. But in your condition, I would not advise you to undergo tracheostomy, which would even reduce your quality of life and uh, even um, that will take long time. That will that will take long time for you to get adjusted with the tracheostomy. And we would try to help you with other medications. And if your breathlessness is unable to manage with the medication that we are giving, then if breathlessness come to such severe condition, we would sedate you so that you would not um, know the breathlessness. Mm. So that is one thing which I would talk to the patient and caregivers. Mm. And so that I can write it in the case sheet, and if you also communicate it with the caregiver, then if she goes into severe breathlessness, then you might also write some orders, anticipated prescription for breathlessness. What should be done in case of severe breathlessness? Maybe fair morphine or whatever. If you have injection morphine, then you have to give injection morphine. Then injectable, if it is there, then probably that would be the best thing. Or if it is not available, then tablet can be given even correctly. And maybe if the breathlessness is not controlled with morphine, then you can add benzodiazepines like midazolam. Maybe you can add it to a drip and can infuse continuously. But for the first time, you may give 1 milligram of midazolam and see how the patient is responding. And according to that, you can titrate the dose of midazolam so that patient is. I think this all would be the discussion that need to be happened with the caregiver and the patient. And if they also are willing um, to go forward with us, then this all should be done in the to be written in the case sheet. So I think probably the patient you should also discuss about withholding the life-sustaining treatments because it is going to be inappropriate at this situation. So withholding life support in potentially inappropriate situation is ethically and legally it is okay.
Dr. Sangeeta, any other sir? There is a discussion on the on total parental nutrition if the rise to was ineffective and causing discomfort. Anything?
Okay, I think considering this patient status, even I would not have put a right to proper patient. Whether I would have advised for subcutaneous hydration, or if that is if the nurses do not know about that, I would give IV fluids. Total parental nutrition, it is not going to help this patient because this patient has a very advanced malignancy. And the patient cells cannot utilize that. So that's another factor. Yeah, Adil says role of steroids. Yes, that's what I wanted to tell you. Maybe even injection dexamethasone. I think if you have used, that might be an advantage for the patient. It will help to reduce the peritumor edema, and it will also help with the pain. So that's something which we can try at this situation. Maybe 16 milligram once daily, and maybe 3 days of trial would help us to understand whether the steroid is going to help the patient. And morphine is going to help with the breathlessness as well as with the pain. So this patient had breathlessness as well as pain. So I think probably she is on 30 milligram of morphine and 10 milligram POD. So if it is pain, I think it should be given every 4 hourly. So 5 milligram 4 hourly, and then you have to titrate the dose of morphine, which will also help to reduce the
Any other questions, Dr. Sangeeta? Anything unaddressed? As everyone mentioned, you did your best for this patient, but is there any other question that you have?
Ma'am, that actually that morphine also we are taking from our tertiary hospital, because we are not yet started getting morphine. So few morphine tablets we had asked from the oncology department of our tertiary hospital, which we are using for our patients. So it was supplied in 10 mg tablet. So instead of breaking it, and like 5 mg tablet was not available, so we started with 10 mg only TID. That was the reason.
Yeah, I think even I don't know whether 5 mg tablets are available. It's okay if you need smaller doses. It is okay to break the tablets. We break up to 2.5 milligram, 1/4 of 10 milligram tablets. And I'm just curious to know why. I mean, your institute doesn't have more.
Ma'am, actually, we have recently only started with palliative care services. So, and that morphine also since last few months, 6 to 8 months back only we started, because patients, they don't come here. We don't have super specialty out here. We don't have oncology, we don't have cancer unit, nothing. So only those patients with complications come to us seldomly. And my attempt was to spread the message of palliative care. So with that, I only was searching for the patients, and then I brought them to my department, and then just tried to give something, counseling and that morphine and all, so that they have a pain-free life. And that much only we are doing, ma'am. Otherwise, because I'm so much busy with my own department, that I cannot give full time to the palliative care also, to be very frank. So I'm building up my team slowly, getting them trained, and even the CIPLA Foundation has agreed to help us. So maybe in future, we'll have a good number of team, then we can be like very actively dealing with the cases and all, I think, ma'am. It's a very small hospital in the periphery. So people also, they have not known about this. I'm trying my best to create awareness and all. So slowly, they are knowing it. And to be very frank, even our doctors, they haven't heard about palliative care. So I have to explain them every time what is palliative care and all. So this training also, ma'am, what I feel that maybe it was not for me, but still I learned at least something out of this, and I'm feeling good also. So it was my small presentation. I don't know, I tried my best. So just wanted to hear from the experts only. That was my motive, actually.
Thank you, Dr. Sreedevi. I'm glad that you started something, even if it is small. The big part is to start something so that you have reached there. So I really appreciate your efforts, even for managing the general medicine patients. You have taken an effort to start something.
Thank you.
Where people don't even talk about palliative care. We are happy to offer any kind of support that you want in future to expand your services. Dr. Sunil, you are about to do.
Dr. Sangeeta, I think you will be going to be busy all the time. So I think it would be good if you can give more training to your nurses so that they can actually talk to the patients and caregivers. You just give orders and the nurses need to carry out those orders, and it will be very helpful for you.
Okay, sir. Okay, sir. Okay, sir. Thank you, sir.
Thank you so much, everyone. Thank you for the presentations. We can wind up today's session. As Rajalakshmi mentioned in the group, we have webinars. So that we'll be informing you in the WhatsApp group. So whoever feels it is useful, please do register for the webinar and attend for the sessions. I hope these sessions were of some help for all of you. And we'll be informing about further training programs in the WhatsApp group. So please keep a track on that and try to attend and gain knowledge through our courses. Thank you so much. If you have more queries, we are happy to address them in the group or as an email. Thank you so much, everyone, for being a part of this refresher course this year. Rajalakshmi.
Thank you, Dr. Sreedevi. Thank you, Dr. Sunil, for that wonderful discussion. Thank you all for being part of this different batches. Like Dr. Sreedevi said, for upcoming programs, we will update you in the group. All the best with all your future endeavors. Thank you all.